Hello everybody and welcome again to a new Radiology Bits video. Today's case is an advanced case in neuroimaging. As usual, when you see this sign, please pause to think about the images and the possible differential diagnosis. These are a few selected CT brain images on a 62-year-old female patient who presented with headaches. Pause here. Now to the discussion part. It's clear that the patient has dilatation of the ventricular system that involves the lateral ventricle, the third ventricle, but spares the fourth ventricle. At this point, you have to think about a cause. Although we know various causes of non-obstructive hydrocephalus exist, this pattern of dilatation that spares the fourth ventricle suggests that there is an obstruction at the level of the cerebral aqueduct. If you look carefully, you'll notice that there is a lesion there that displaces the calcification of the pineal gland posteriorly. Let's go to more images. These are selected MRI images on the same patient. Pause here. This is another image as well. Pause here. Let's go to the findings. The MRI images show that the lesion in the pineal area is hypointense on T1, hyperintense on T2, and enhances after administration of IV contrast. This sagittal image nicely demonstrates homogeneous enhancement of the abnormality. Before we continue, let's look at a little bit of anatomy. This is a sagittal image in the midline of a normal patient. Enlarging the area of the pineal region, you'll see that the pineal gland actually lives in front of the third ventricle, below the splenium of the corpus callosum. It has a close relationship to the midbrain, in particular the posterior part of the midbrain that is called the tectal plate or the tectum, and it has a close relationship to the cerebral aqueduct. Lying in between the splenium and the pineal gland is the internal cerebral vein that curves to continue as the vein of Galen before communicating with the inferior sagittal sinus and forming the straight sinus. To show this relationship better, let's look at an enhanced sagittal image on a normal patient. And these are your venous structures curving underneath the splenium. So knowing this bit of anatomy, what are the possibilities that could explain this abnormality? The easiest way to think about pineal region abnormalities, or masses in particular, is to divide them into abnormalities that arise from the pineal parenchymal cells themselves, lesions that are related to germ cell tumors, and abnormalities that arise from surrounding structures. If the lesion were to be a pineal parenchymal tumor, one possibility would be a pineocytoma, which is a low-grade tumor that could happen at any age. It could occur in adults or in pediatric age groups. This abnormality could have various appearances on MR. It could be homogeneous or heterogeneous, may contain cystic components, variously enhancing solid components, and calcifications. One important point of this lesion is that the calcifications, if seen, they're usually exploded outwards, similar to what we saw in our case. A second possibility would be something called a pineoblastoma. Now, this lesion is a pediatric age group abnormality. It has various appearances as well. However, it's famous for being invasive and gives drop metastases within different CSF spaces in the brain and around the spinal cord. Since this lesion is also arising from the center of the pineal gland, it also leads to explosion of the calcifications outwards. Now, pineocytoma and pineoblastoma is what you really need to know. You might come across a few rare entities when reading about this topic. However, These entities, as we just mentioned, are very rare and very difficult to differentiate from the more common pineocytoma or less common pineoblastoma. What about germ cell tumors? The most common germ cell tumor that occurs in the pineal region is a germinoma. And germinomas are classically seen in younger male patients. Appearance-wise, they're homogeneous tumors that show intense enhancement after intravenous contrast administration. A very important fact about germinomas is that it engulfs calcifications. So the calcifications compared to the pineocytoma and pineoblastoma, instead of being displaced outwards, may be in the center of the pineal gland abnormality. Germinomas share a few characteristics with pineoblastomas. First, they're highly cellular tumors, so they might show spontaneous hyperdensity on CT scan or hypointensity on T2 weighted imaging. A second feature is that they are commonly invasive and give early drop metastases. A simple clinical trick to use to differentiate germinoma from pineoblastoma is to order tumor markers such as alpha-fetoprotein. These specific tumor markers are commonly elevated with germinoma. The second most common type of germ cell tumor occurring in the pineal gland region is a teratoma, and these are more characterized by being heterogeneous, containing various components such as solid components, calcifications, cystic components, and fat. There are a few other germ cell tumors, but if you know germinoma and teratoma, you're good to go. Do not forget that you might have abnormalities that arise from structures that surround the pineal gland instead of arising from the pineal gland itself. Remember that you have the tectile plate, so you might have a tectile plate glioma. You have meninges, so you could see a meningioma, and several other entities if you consider the anatomical structures that live there. Given that our patient is 62-year-old, she's a female, the lesion was homogeneously enhancing with no features to suggest invasion or drop metastases, and I'll add that the tumor markers were negative in her case. All these factors favored pineocytoma. The take-home point from this case is, when you see hydrocephalus, please make sure you're not missing a cause, since hydrocephalus may be obstructive or non-obstructive in nature. Another practical point for radiology residents when looking at brain CT cases, midline lesions are very difficult to see unless you look for them actively. So always check for your midline structures and make sure there is nothing extra in that location. A third take-home point is when you're differentiating pineal gland lesions from each other, first of all, try to find the pineal gland to make sure that the lesion is arising from the pineal gland instead of from something that surrounds it. Number two, if you think it's pineal in origin, try to assess the calcifications. Pineal parenchymal tumors such as pineoblastoma and pineocytoma would explode the calcifications. That's in comparison to germinomas, which would engulf the calcific components. Thank you for watching. Please share our videos, subscribe, like, and join our Twitter account. See you later.